Assalamu alaikum. Today we are dealing with another VesicoVaginal fistula. This is a 45 years old lady who underwent total abdominal hysterectomy 4 months back and then developed incontinence. We saw that the cystoscopic findings, so we went through the vagina and past this ureteric catheter, and then we'll bring this catheter out through the urethra. This is to identify the fistula while performing the dissection between the bladder and the vagina. Now we go into the abdomen, create pneumoperitoneum and release some bit of adhesions. The steps of laparoscopic vesicovaginal fistula repair are the same as that of the open repair. Here you can see that we have got a huge cyst on the left ovary. However, we will be performing the procedure superior to this side, so we will not mobilize any further. You can see this. There is a balloon in the bladder, the catheter balloon. So we start dissecting between the bladder and the vagina. So we will be discussing the steps again. The steps are the same as that of the open repair. So we open the bladder, identify the bladder, and then open it, and then identify the site of fistula, which in this case will be visible once we open the bladder. We'll be able to see the ureteric catheter going through the fistula, and then we will bisect the bladder up to the fistula, and after bisecting the bladder and reaching up to the fistula, we will cut the ureteric catheter and just remove it, and then we'll separate the bladder from the vagina, or from the vagina from the bladder, creating enough of a flap of the bladder which is around 1 centimeter in order to repair the bladder. We will separate and excise the fistula tract, and then the vaginal vault will be repaired in 2 layers. In this case it is a small fistula, so it may need only a few stitches rather than a complete repair. And then we'll place a viable tissue in the form of peritoneum or a mobilized vascularized portion of the omentum, or most likely the fatty epiploiky or appendages of the sigmoid colon. I prefer the appendage of the sigmoid colon because there is no question about its viability. The tissue which is placed between the 2 repaired layer must be viable. It should not be bleeding, because a small collection of blood or a clot may lead to infection, inflammation, and then erosion, and maybe a recurrence of the fistula. So it should not be bleeding. That is one thing. Another thing is that it must be viable, because if it is not viable, it again invites inflammation, infection, and hence recurrence of the fistula. So keeping in mind all those things, in my opinion, bringing the fat of the sigmoid colon in between the tissue is a good option, but care must be taken. Although in our part of the world diverticular disease of the colon is not very common. However, it may not be that uncommon, so care must be taken not to take diverticulum of the sigmoid into the stitch, because this may create a lot more problems rather than VesicoVaginal fistula. So care must be taken. So here we find that we have opened the bladder, and now we are bisecting the bladder. As we all know that dissection is not possible without traction and retraction. So any surgical procedure is just a combination of traction and retraction and a dissection in between. So in laparoscopy it is a bit difficult because we have limited instruments inside, and we may need additional ports for traction and retraction. So here we identify the fistula, and then we have changed our line of bisecting the bladder towards the fistula side. So we cut the ureteric catheter. Now we are excising the fistula tract. The advantage of this excision is that the edges of the bladder are automatically refreshened, so they are healthy because the fistula is very small and fibrosis is minimum. So just cutting around the fistula, we have automatically achieved fresh margins of the bladder. Now we will try to dissect between the vaginal vault and the bladder, but care must be taken not to make another opening or a hole in the vaginal vault, because if that goes unnoticed, it will be a reason for forming another fistula or a reason for the failure of repair. Care must also be taken during mobilization about the ureteric orifices. One assistant must keep an eye on the ureteric orifice, or must remind the surgeon every 3 to 4 minutes about the ureteric orifices, because one of the most common complication of vesicovaginal fistula repair is injury of the distal ureter and of the ureteric orifice. Now here we can see that we have found the plane between the bladder and the vaginal wall. Yes, here. So we try to extend this plane towards both sides. As we can see that the fistula is very small. Even a single stitch may be able to close the hole in the vaginal vault. So this is the fact that we will place in between. So no more mobilization is required here. So we clean the area, then we place the sutures. So we place the fat in between, which is coming very easily without any tension. So this is the first stage. In the open procedure, I mentioned in my previous video as well that we usually use Vicryl 1, which has got a strong needle, and the suture is also very strong. Here we will use Vicryl 20. The vaginal wall is very thick walled, and it is a tough layer of tissue, so at times it is difficult for the needle to pierce the wall. So it may require some force, or the needle driver may not be able to keep the needle in the same angle, so it keeps on rotating. Here you can imagine how difficult it is to pierce it with the 20 Vicryl needle. However, purpose-built sutures are now available and developed thanks to Ethicon Surgical. They now have developed a suture which has got a very sharp needle. It can pierce any tissue, any fibrosis, any hard tissue. So that suture can be used for the repair. However, it is worth mentioning here, and thanks to the Ethicon Surgical, that they have made available to us a suture by the name of Stratafix. Stratafix is basically a monofilament PDS suture. It is available in 30 and 20 sizes. I'm mentioning it here because in laparoscopic surgery, this suture has got a very good outcome and a very good stitching, because laparoscopically, as I already mentioned, that you don't have the freedom of using your hands. You can't change your angles. You can't use stronger needle holders. So you have got a very limited space. You are dependent on the port sides, so you have to adjust. So in the Stratafix suture, the important thing is its needle, number one. Here you can see that this is a Vicryl 20, but we'll be repairing bladder with the Stratafix, so you'll be able to feel the difference between the needle of 20 Stratafix and the needle of 20 Vicryl. And another important thing of the Stratafix suture is that it has got a pre-formed loop. So for the first stitch, you do not have to do the knotting. You can go through the loop and then just pull the suture, and it can hold itself. And the third important feature of the Stratafix suture is that it is a barbed suture, and the barbs are in such direction that when you pull the suture once, it does not loosen up, so it holds itself. Here you can see that after repair of the vaginal vault, we have fixed the viable fat tissue over the vaginal vault repair over the suture. So the two sutures, the sutures of the bladder repair and vaginal vault repair, will not be opposing each other. So there will be a minimum risk of recurrence of the fistula. So a little bit of cleaning, and you saw that we removed both the needles. It is important to count the needles and remove all of them, because in the pelvic cavity, transperitoneally, there is a chance that we may lose a needle, and it may have its complications post-operatively. So a needle count is a must. As a basic ABC of surgery, I don't have to discuss here. Here you can feel the difference of the steel between the needle of the Vicryl 20 and the needle of the Stratafix. So the first stitch is taken outside in and then inside out, and now we are going through the preformed loop of the suture, and you can see very easily that after pulling it, the suture will be able to hold itself. So the advantages of using Ethicon surgical Stratafix suture are: number one, a sharper and a stronger needle, and number two, it is monofilament. Number three, it is antibacterial coated, and number four, it is self-holding. So we don't, after pulling the suture, we don't have to worry about the fact that it may get loose, and so it is very good for reconstructive procedures like VesicoVaginal fistula repairs, like pyeloplasties. We usually do pyeloplasty with a 4-0 suture, but this is not available in 4-0 strength, so a 3-0 suture can be used. So the needle can be seen very easily piercing through the tissue. We must not forget the fact that bladder is not as tough as the vaginal wall. However, the needle is also very good. The disadvantages must also be discussed. So while discussing the advantages of Stratafix suture or a V-lock suture, the disadvantages are also there. So they need to be discussed as well. So the first one is that as it is monofilament, it needs to be handled carefully, because it may break if we are repeatedly handling the suture and holding it tightly. This may break. Second disadvantage is its handling is difficult, like the handling of proline. Vicryl is easy to handle. However, handling of this suture in laparoscopy is a little bit difficult as compared to vicryl suture. But the advantages overweigh or overshadow the disadvantages. And the third disadvantage is that it is a little expensive as compared to vicryl suture. So here you can see that the suture is beautifully holding the two edges of the bladder together, and now the upper edge we have stitched so that we know where is the upper end of our incision in the bladder, and also an assistant is holding that suture for us. So it is acting as a retraction as well as a landmark for the upper limit of our incision. So how beautifully, when you pull the suture, it holds the two cut edges of the bladder. And from time to time, when the suture comes near to the camera, you can see the barbs or the spikes on the suture, which are responsible for the holding of the suture in place. Once again, I will briefly discuss the principles of repair of VesicoVaginal fistula. Number one, proper identification of the fistula's track. Number 2, confirmation of the fistulous tract, whether it is single or multiple, because a missed fistula is another factor for failure of fistula repair. Then is proper dissection in the dissection plane between the vaginal wall and the bladder. They always say that excision of the fistulous tract, and then refreshing of the margins, especially those of the bladder. Dissecting the bladder at the vaginal wall minimum for 1 centimeter, so as that bladder can be, the bladder edges can be approximated. Maintenance of the vascularity during the dissection. Vascularity must not be compromised. If there is any doubt that the vascularity has been compromised, it is really important to refreshen those edges once again. And then closure of the vaginal vault, basically in 2 layers. And then placing a viable tissue between the suture line of the bladder and the vaginal wall. The repair must not be under tension. And then repair of the bladder, and adequate drainage in the form of perurethral and suprapubic catheter must be provided, so that if one catheter gets blocked because of clot or anything, the second catheter must be there for the drainage. We keep the suprapubic catheter for 2 weeks, and after 2 weeks we remove the catheter, and perurethral catheter is kept for another week, and the vaginal pack is removed on the first post-operative day. So we cut this stratified suture, remove the needle, remove the other needle of the Vicryl 20, wash all the area, and then fill the bladder. This will check that the bladder is being filled and there is no leakage, and also will help us placing the suprapubic catheter, and then drain is placed, and the rest of the post-operative care is the same as for any other surgical procedure. I hope you like the procedure. Please like and subscribe to the channel and forward it to your colleagues. Thank you very much.